Hey everyone, this is Dr. Tom Moorcroft, and welcome to this episode of the Lyme Insider Podcast. Today I am joined by veterinarian researcher extraordinaire Dr. Ed Breitschwerdt, and he is over at North Carolina State University where he's doing tons of research. He's a clinical professor and he's clinically seeing animals, many of whom are dogs and cats, in his daily practice, but he's also doing groundbreaking research on diagnostics in Bartonella and even in the genus Babesia now. And he has the Melanie S. Steele Distinguished Professorship in Medicine, Professor of Internal Medicine title over at North Carolina State University. And he also is the Chief Scientific Officer and co-founder of Galaxy Diagnostic Labs. So in our episode today, we are going to dive deep into Bartonella. We're going to be talking about what we know, what we don't know. We're going to be going over diagnostics, both antibody serology tests and more advanced and newer direct testing methods so that we can really slam dunk our diagnosis in our patients as best as we can with the science available today. Dr. Breitschwerdt is going to talk to us about the history of Bartonella, and he's also going to talk about where we're going and the things like what he wants to do most before his career ends to really help minimize the impact of Bartonella and other infections on patients. The other thing is we're also going to be talking about some of the presentations of Bartonella, particularly several case reports where we see neuropsychiatric presentations. So some of the things you wouldn't think about if you just think about Bartonella Henselae as causing cat scratch disease or Bartonella quintana causing trench fever. So join me for this action-packed episode, diving deep into the science, stuff that you may never have heard before, and also very actionable things. So you're going to come out of this podcast episode really understanding Bartonella at a whole new level. I want to say thank you so much for joining me and enjoy this episode of the Lyme Insider. Well, Dr. Ed Breitschwerdt, thanks so much for joining me today. I really appreciate you joining us on the podcast to share your wisdom and your knowledge, and looking forward to having our conversation.
Thanks, Tom. I appreciate the opportunity.
Yeah, one of the things that I find interesting is I think of you as like the Bartonella guy, right? Because like when I kind of got into Lyme and co-infections, like I started to hear research being done with Bartonella, and you were always at the forefront of that. And some of the papers that have come out of your lab and have just been incredible. Like, hey, we don't see Bartonella in ticks in the Northeast, but you're seeing it in North Carolina. So I definitely want to dive into that and some diagnostics. But one of the things that always interests me as just a human being, as well as a physician, is what got you interested in doing this kind of work? Your background as a veterinarian, you're doing all this. How do you get into Bartonella?
So when I joined the faculty at North Carolina State University, which was actually in 1982, a long time ago, I had taught in clinical veterinary medicine, neurology, nephrology, and cardiology because, if you go back 20 years before that, we didn't have as many specialists as we do now in veterinary medicine. So those of us in academia many times would have to teach a discipline that was, and as an internist, I was fairly broad, but I certainly wasn't a cardiologist or a neurologist or a nephrologist. But when I came to NC State, I had published a number of case reports, case series in veterinary medicine on unusual infections that occurred in animals. Generally, dogs and cats were my patients. And I started working with David Walker, a MD pathologist at the University of North Carolina. And David, honestly, is one of the premier rickettsiologists in the entire world. And so we started with Rocky Mountain spotted fever, which in retrospect was a good place to start because the disease in dogs is identical to the disease in humans. We were able to isolate rickettsia in my lab, which required a BSL-3 lab at that point in time, which David helped us establish here. And it's an acute infection. And as well as we know in dogs or humans, if you have that infection, you clear the infection or you're treated with doxycycline and your physicians help you clear the infection. But there's no chronic aspect. Mm-hmm. We then went on to do work with Ehrlichia and Babesia and Borrelia in the context of Lyme disease in dogs, all of which were far more complicated than rickettsia and Rocky Mountain spotted fever. And it was because I was a member of the American Society of Rickettsiology and attending their meetings that I got to hear Russ Rignery at CDC say, we finally found the organism that causes cat scratch disease. And as you know, in scientific meetings, sometimes the most important thing is what happens in the bar after the meeting that night or at breakfast the next morning. And just so happened, Russ and I ended up having breakfast at the same table. And I asked him, Russ, how hard is it to isolate Bartonella? And he said, Ed, if you can catch 3 feral cats in Raleigh, you're likely to get 1 isolate. So that was good because the organisms, whether it was Rickettsia or Lichia, that we had worked with previously were very, very difficult to isolate. Mm-hmm. So that's what got us started in essentially about 1992 with a PhD student looking at Bartonella in cats.
That's like, it's so interesting. It's like, just kind of be at the right place at the right time and either sit down at the right bar stool or the right breakfast table.
Absolutely. So, yeah. I think back on that particular conference because it was a good chance that I might not have been there. And it was fortunate that I was. It was actually at Rocky Mountain Laboratories out in Montana where, Rickettsia and Rocky Mountain spotted fever became so famous. So it was great. That was the first visit there. But I left that meeting less enthralled with Rickettsia and much more enthralled with this new genus of bacteria that was discovered in AIDS patients a couple of years before that.
Yeah, it's so interesting. I mean, I feel like a lot of us think that these things have been around for a really long time. I mean, obviously the organism has been, but we have this really deep medical knowledge of these things. And it's like, oh, we discovered it in the 80s, right? Which is not that long ago in terms of medicine, right? I mean, and I wonder, like, what are some of the challenges here with Bartonella, though? And like, why was it just kind of coming out then? And what have you seen over the last, say, 30, 40 years in terms of like, why is it so challenging to work with? Why is it so, I mean, so many of us are like Bartonella in people, which I'm sure we can get to some of how, some of the other papers you've published and the patients I've worked with, but what makes Bartonella so special? Or it almost seems different.
I think it's a pretty amazing story. And I think it's a story that people will be looking back at and writing about well into the future. And why I believe that is it is an accurate statement to indicate that we did not know that any Bartonella species infected a cat, a sheep, a cow, a human in North America before the AIDS epidemic. So it took HIV, it took severely immunosuppressed individuals for them to then develop a lesion in their skin or in their liver that pathologists could see bacteria. And yet microbiologists for 2 to 3 years could not grow those bacteria that the pathologist was seeing. And it took David Relman at Stanford to use molecular approaches to ultimately say, oh, gee, we know about one of these bacteria. It's Bartonella quintana, which is the cause of trench fever in World War I. And oh, by the way, we just found this new bacteria in the AIDS patients, and that became Bartonella Henselae, the one that is endemic in cats, endemic in fleas, and causes classical cat scratch disease. So I think we now know that there's, and it's very hard to keep up with the current literature, but over 50 species of Bartonella. So we went from not knowing they existed to 2 species, Bartonella Henselae, Bartonella quintana, and I should acknowledge Bartonella bacilliformis, which was also the original Bartonella down in the Peruvian Andes. So now we're up to 50 species. And for veterinary medicine, the biggest challenge is that we're taking care of all the animals that have, on, as you alluded to, an evolutionary basis, co-evolved with generally a vector and with the specific Bartonella species. An example is I happen to live on a farm and I have beef cattle, and studies we did 15 years ago, 80% of my cattle have Bartonella bovis in their blood. So, yeah. So we didn't know Bartonella bovis existed before the AIDS epidemic. It was subsequently found after that. And what's also, I think, very timely is within the last year, a veterinarian in Mexico who was vaccinating cattle managed to stick the needle into his chest during the vaccination process and transmitted Bartonella bovis from the cattle he was vaccinating to himself. So just an example, you ask, how has our knowledge of Bartonella changed? It's changed very dramatically.
So in that case, like, because I know some people listening go, oh, now Bartonella bovis is something that a human can get. Like we see a lot of this. It's just like you hear one case of somebody with an accidental needle stick. But I guess I'm curious, did he actually get sick from that? And I mean, I'm making an assumption, but I could be completely off base. Is like, we generally don't see Bartonella bovis in a human being, or at least we're not able to figure it out. I mean, do we have any knowledge of that, or?
Yeah, he would be the first case. There was one previous abstract from South America suggesting that Bartonella bovis had caused endocarditis, but it never got published, which probably means that the molecular data supporting that probably wasn't strong enough to make a peer review. So this individual literally is the first human case of documented Bartonella bovis infection.
Mm-hmm.
On a molecular basis. And yes, he did get sick. He kind of got swelling, abscessation, lymphadenopathy, and fevers. That was the reason he ultimately went to his physician.
That's wild. But again, yeah. I mean, he poked himself with a needle by,
Yeah. So there's
three
needle stick transmissions now to veterinarians. One we published where one of our dermatologists actually put a needle into a cancer, a neoplastic lesion in a dog, and the dog jumped at the time, and she put it into kind of the meaty part of her hand, and she transmitted Bartonella winsonii burkhoffii. It's a canine adapted Bartonella. And then another veterinarian over in Taiwan, again through needle stick, where they were collecting blood from a cat, managed to transmit Bartonella Henselae from the cat to himself. So in veterinary medicine, we have been a little bit lax in worrying about needle sticks compared to human medicine for obvious reasons. And right. I think we need to pay a little more attention now.
Clearly, I mean, having been someone in the ER who was assisting and got a needle stick, I mean, it's a scary situation. I mean, you don't know what you're going to get or what you're not going to get. So, I mean, I think it's something that we have to be careful about. So most of our listeners hopefully are not going to be somebody who could be exposed to a needle stick, although some of them may be if you're a healthcare practitioner in the ER or you're a veterinarian. But one of the things that I've always been really impressed with coming out of your work is that I learned something new about transmission. I feel like I went to medical school and they said, Bartonella Henselae is a causative agent of cat scratch disease, and you get a cat scratch or a cat bite, you might get a little, pustule, but essentially it's usually self-limiting, and don't worry about it that much, which, that's been updated a little bit. But what are the ways that you're seeing the different Bartonella species, like what are their vectors and how are they being transmitted to humans?
So that's a great question, Tom. And you asked what makes the genus Bartonella unique. One is now we've discovered all these species with a large spectrum of animal reservoirs that goes from rats to bats to everything in between. But the other thing that makes this genus unique is the fact that it can be transmitted by so many different vectors. And we know that Bartonella quintana, for instance, is transmitted by the human body louse. We know that Bartonella bacilliformis in South America is transmitted by a sandfly. We know that fleas transmit at least 3 Bartonella species to cats. Bartonella Henselae, which is the one that causes cat scratch disease, but Bartonella clarigiae and Bartonella cholerae, all of which have been isolated from humans and isolated from blood. And then in addition to that, there are ant bite reported cases of Bartonella transmission from the United States and from Australia. We have reported rat mite transmission to a woman who was the owner of 2 papillons, these little small dogs. And the story there is interesting, and it's an important one because they had raccoons. She had raccoons under her house. She had someone come in and trap the raccoons and take them away. The tropical rat mites were, one, not so tropical because they were in upstate New York, but the other problem was they were very happy as long as there was a blood source that was called a raccoon. Once the raccoon was gone, they actually worked their way through the plumbing up into the house and infested the dog and infested the owner. And we were able to isolate Bartonella Henselae from rat mites that had actually been collected, or at least we could amplify and sequence the DNA from them. But we could also isolate it from the dogs, and the woman subsequently developed neuropsychiatric symptoms, and we proved that she was infected as well. So, again, this is what makes Bartonella such a complicated story, I think, is, tropical rat mites are not supposed to be involved in the transmission of Bartonella, but yet it's pretty obvious that they are. And similarly, French researchers proved, pigeon mite transmission of Bartonella quintana, where a person, an exterminator, was cleaning out, pigeon nests up in an attic, and that person became infected, as did the investigator that went there to try to understand what might have been going on epidemiologically. And both these individuals end up with Bartonella quintana and pigeon mites.
Yeah, see that's so wild to me, because one of the things that I come across, and like I have the Lyme disease practitioner, certification and mentorship program where I take people like myself who are starting here, seeing people who are suffering with these weird things, and they're willing to investigate and stand up for the patient's rights and autonomy, and they really want to just get to the bottom of this. And one of the things that we talk a lot about is kind of like this conversation, like what's the real science behind it, not just what's out on the interweb or whatever, or on social media, but like what's the real science. And I always say to people, like when they talk about Lyme disease, they're like, we start talking about conspiracy theory and this and that. I'm like, that stuff might be real, but I'm like, talk real science, right? Because I mean, the science about Lyme and Bartonella is kind of damning. You don't need anything other than pure science to be afraid of it. And one of the questions that always comes up for us is everybody's like, why is there so much Bartonella? I'm seeing all these people with Bartonella. And I'm like, it's one of the things that we call tick-borne, right? In kind of like the big three, people talk about Lyme, Babesia, and Bartonella. But it's really hard to get Babesia without getting Lyme. But you can get Bartonella all by itself because the vectors there's a ton of vectors. And I've talked to teachers who are like, I'm doing a public talk or whatever, and we say, hey, I said, well, you can see lice transmission. So if you see neuropsychiatric symptoms going through your classroom, and like they're all like, you hear the back of the room, because like they all see it. They get lice go through the classroom. Somebody has acute ADHD. Somebody has all this rage and starts acting out. Somebody else has like new OCD or anxiety, and it's just crazy. But I think what you're highlighting, at least for me, is the reason that we may see more Bartonella, say, than the doctors are expecting is because there's a myriad of vectors, and it sounds like we don't even know what they all are at this point.
Absolutely. And I think you brought up two things that are very important and somewhat related. It is very clear that laboratories around the world have amplified Bartonella DNA out of ticks. And there have been some laboratory studies, including tick attachment animal studies, that have documented transmission of Bartonella. Most of these studies, though, have not documented the transmission of those Bartonellas that infect humans most often, like Bartonella Henselae or Bartonella quintana, or Bartonella vinsonii burkholfi, which I would say are amongst the top. So we know from the United States and Central America, South America, that if you collect ticks and you have good gene targets to detect DNA of Bartonella, you can prove that ticks are infected. But proving that they're competent vectors has been far more challenging, and a number of labs are working on this currently. And I think my opinion is there's no question that ticks are capable of transmitting Bartonella. How often that occurs in the United States is still a very open question. And so, yeah, we're working on that. Some others are working on that. And I'm hoping that we'll see some publications in the future that provide a little clarity as to, exactly what's going on in regard to tick transmission of those that are important. And a similar situation actually exists with head lice versus the human body louse. So the way Bartonella quintana was recognized, and it was in World War I when soldiers were in these very wet, very nasty condition in the trenches, and it was cold, it was wet. That's what human body lice love, that type environment. Right. So they proliferated. You can go on the internet and find pictures of them putting DDT all over soldiers to kill these lice while they were down there because they were so irritating and they'd scratch. And it's actually similar to the situation with fleas, where it's the louse's feces that contaminates the wound that a soldier creates when he scratches. That's the transmission. Same thing with cat scratch disease. It's not the cat that is infected with the Bartonella that's necessarily the source of the infection. It's the flea that's taking a blood meal from the cat that becomes infected with Bartonella, that has Bartonella Henselae in its feces, that ultimately contaminates the nails or the saliva and results in transmission. I think a really important thing is we don't know whether hid lice are actually a threat for Bartonella quintana transmission at this point in time, despite the fact that labs around the world have documented Bartonella quintana in hid lice.
It's kind of interesting because it's just like, I'm just thinking in the back of my mind of like, of all the things that I've been taught, and we assume that, like with Borrelia burgdorferi, Lyme disease, the causative agent of Lyme in the U.S. at least, everybody's like worried about the deer. But then I heard some research, out of University of Binghamton, where they're like looking at like some of the ticks that are feeding on the deer have a very low infectivity rate, but the ticks that are feeding on rodents have a higher, kind of more what we would consider the normal 30-40% or even higher rate of infectivity. But I think it's like we hear like it's a deer tick, so then we're just like, oh, the deer are the bad guys. And like here you're saying like it's not really the cat that's necessarily the issue, it's the arthropod that fed on it that then pooped on it. And so, I mean, I just think that it's really interesting to get down to the nitty gritty of how this is actually happening, so we don't start like offing all our cats and
right.
stuff,
Well, I was actually contacted maybe 2.5 years ago by a neuro-ophthalmologist at Emory University, and we published a paper on, in the neuro-ophthalmology literature on what to do with a cat if a person develops neuroretinitis, which is a classical abnormality caused by Bartonella Henselae when it's transmitted from a cat to a human. And what you just said is the primary thing. One, eliminate fleas and make sure you keep your cat indoor, and make sure you don't introduce another cat into the household that has fleas, and then avoid, bites and scratches. But currently, if a cat doesn't have fleas, there is very little evidence supporting the fact that that cat can transmit Bartonella.
So that's kind of interesting because I get asked this question all the time. And I mean, is like, people are like, I have Bartonella, we have a cat. Should we test the cat and treat the cat if the cat's positive for Bartonella?
So I think the CDC website would say, no, do not test the cat. And I think most veterinary infectious disease type, including myself, would say if you have a healthy cat and perhaps you don't have very young children or you don't have an immunocompromised individual in the house, I probably wouldn't test that cat.
Right.
And part of the rationale is, and we'll perhaps get to this later in the discussion, is we are also learning that eliminating Bartonella is far more difficult than what we had historically considered. So we did studies early on after Russ Rignery told us that cats and cat scratch disease was caused by Bartonella Henselae. That very first PhD student, we actually infected cats by blood transfusion from 2 cats that had induced either classical cat scratch disease or one that induced neuroretinitis in a patient over at UNC. And so we treated those cats literally for a month with doxycycline. They didn't clear the infection. So we knew back in the early 1990s that a drug that works extremely well for rickettsia, for Borrelia, for anaplasma, for some of our other tick-transmitted diseases does not work well to eliminate Bartonella. And, it is true, and you alluded to this, that it's likely that most people that acquire cat scratch disease clear it immunologically. But we have published on people that got classical cat scratch disease and, within a year or 2 years of that diagnosis, we could document that they still had Bartonella Henselae in their blood and they had gone on to develop seizures, as one example.
Right. It's interesting because I keep in the back of my mind going, when are we going to get to this part? But it's that one of the biggest, to highlight one thing that I know we'll come back to in a little bit, is there are some very interesting neurologic, ophthalmologic, and even neuropsychiatric presentation of Bartonella that I think are very understood and underknown, if that's a thing, but except maybe in some of the circles that you and I travel, because we're the people who are talking about these possible, relationships between Bartonella species and these neuropsychiatric presentations. And I know you've published on that with multiple people that are good friends of mine. And also, I do this all day, every day. But before we hop into some of that stuff, one of the questions that I think is really important, I came up with this I picked a crazy quote when I got out of high school. I don't understand why it came to me until 30 years later, and I started to understand it. But there's a James Thurber quote that says it's better to know some of the questions than all of the answers. And so I'm always my question is, how do we get a good diagnosis? Because so many of our patients and our doctors are talking about the challenges with testing this. And I know in Borrelia, culturing Borrelia has always been kind of we talked very briefly before we hit the record button about gold standards. But with Borrelia, you can put fill 5 culture tubes and only one will grow if you artificially spike them. So Borrelia for some people, have been challenging to grow. But what's going on with Bartonella with, sort of testing it? Because I know you talked about the genes and how we're finding it, but how do we confirm it in somebody, and what are you seeing as sort of challenges either in the veterinary literature or in your work with Galaxy Diagnostics in terms of in human infection as well?
So I think it's very clear that it's easier to diagnose either through serology or through PCR testing or culture an acute infection. Once you get, and that's not always easy, and it varies for each infectious agent, but during the early stages of an infection, the immune system hasn't revved up and isn't doing a great job in suppressing the organism. So there tends to be a lot of organisms in the blood, and the immune system recognizes that. And one of the things we don't do enough in veterinary medicine or human medicine is documenting seroconversion. And that's essentially going from an antibody negative state to an antibody positive state. And so serology can be very helpful in an acute infection. PCR is generally more sensitive regardless of what organism we're talking about in acute infection, because the longer that infection goes on, the less organisms there are in the blood. And that's because some organisms, as you well know, like Borrelia burgdorferi, are for the most part transiently in the blood, and then they end up in the tissues. If we talk about relapsing fever Borrelia, of which there's a whole lot of different species around the world, they typically cause a relapse at 5 to 7 days. So they're in the blood, out of the blood. And Bartonella does the same thing. Trench fever was called 5-day fever. And it's because these organisms want to persist once they get into the host, meaning the patient and meaning us, and they don't want to continue to fight with the immune system. So they keep changing their surface proteins or carbohydrates or other aspects of their outer surface so that the immune system eventually calms down and says, well, maybe I've eliminated this thing. I can't find it anymore. Or the immune system on an evolutionary basis is smart enough to say, I've got to stop fighting this thing, or I'm going to induce an immune complex polyarthritis or glomerulonephritis or organ damage. So, I often tell our veterinary students when I lecture in infectious diseases, when I wake up each morning, there's one system I want to be sure is working. And that's my immune system. Because if it's not, then, if I see COVID or if I see flu or if I get bit by a tick, there's a lot of bad things that can happen if that immune system isn't working properly.
Absolutely. So you're saying PCR maybe to find DNA might be better early in infection. We should check on those antibodies. But what are you seeing kind of in people with chronic infection? Because I mean, like you
Absolutely.
said, acute, there's a bunch of organisms that are traveling to wherever they want to be. And our immune system is like, whoa, this isn't us. But then eventually, like those two things happen that you were just alluding to. But what about in chronic infection? What are you seeing there? What are are there any challenges to diagnosis at that point?
Absolutely. That's where the greatest challenges exist. And that's where the controversies essentially come from. And Galaxy Diagnostics, certainly based on my input over the years and others, is very focused on direct detection of organisms. And you can directly detect an organism by culturing it or by detecting an antigen that sloughs off the surface of the organism, or by finding a DNA fingerprint, similar to going to a crime scene and finding DNA of someone that committed a crime. And so, why, for me as a researcher, direct detection is so important is there's less controversy. If I can put a DNA fingerprint on a Bartonella species and say to you as a physician, you sent me a blood sample and I found Bartonella elizabethae DNA. You have to decide what you're going to do with that. But what I know is Bartonella elizabethae lives in rats. And there are rats in New York City, Baltimore, and all over the place. And a high prevalence of them have Bartonella elizabethae. And it's caused endocarditis in humans. It's caused endocarditis in dogs. So we don't have to debate, is it a pathogen? We don't have to debate, does it cause a pathology? But the other problem that you kind of alluded to, Tom, is that's fine if you've got a pathology or disease like endocarditis, where you've got a localized infection in the heart valve. That is not what many of these chronic infections do, where you have good days, you have bad days, your symptoms change over time, and you go from seeing your rheumatologist to your neurologist to your psychiatrist, and a number of specialists in between.
Yeah, I mean, just I'm taking a couple of notes because these things it's intriguing to me. I mean, with Bartonella, I mean, I don't know if there's you've noticed a difference in the species, but at the genus level, Bartonella, what are you seeing in terms of, like, I know that, like, as an example, like when I speak with Babesia researchers, and I know that your whole life is not only Bartonella and you work with Babesia too, but like they say that, like, it's common to see recrudescence of Babesia. Like, you treat it, it goes out of the bloodstream and then it comes back. But what are we seeing with Bartonella? And I mean, are there, because I think with those waxing and waning symptoms that you described, this is what our patients are experiencing. I mean, do we have any kind of, pathophysiologic understanding of why that may happen in a chronic Bartonella infection?
Well, I think it definitely happens in chronic Bartonella infections. And we've got good examples from the veterinary medical side, as well as good examples from the human medical side. We also have a research study funded by the Cohen Foundation that is literally starting now. It's taken a year to get everything in place with Mount Sinai University. So we will be looking for Bartonella, Borrelia, and Babesia DNA in blood specimens from individuals that develop long COVID. And that's a reactivation syndrome, right? And the question is, I am sure in patients with long COVID, it's not just any of what we're now referring to as the 3Bs, Bartonella, Borrelia, and Babesia, but it's other organisms that are reactivated. And there's already good published evidence of, like, Epstein-Barr virus reactivation in patients with long COVID. So organisms that we carry in our bodies for long periods of time, which right now the medical literature does not support for very well for Bartonella, Babesia, or Borrelia, in regard to that being a prevalent group of organisms that are there chronically. But I think that's going to change. And it's going to change based on direct detection and the proof that on a molecular basis we can find DNA of these organisms. So going back to the other question that you asked me, a research scientist joined me as a postdoc 20 years ago, and he's either first author or second author or last author on many of the manuscripts that we've published on Bartonella, which is about 180, I think, now. And when Ricardo joined me, because it gives you an idea of how hard what we're trying to do really is, regardless of what diagnostic lab or research lab it is, he said, okay, Ed, I'm here. I'm from Argentina. I did my master's PhD in Puerto Rico. I've been working for a company in Italy, and now I'm a postdoc in your lab. What do you really want me to do? And I like the guy because it's no bullshit. It's, what do you really want me to do? Ricardo, I'm a clinician. I'm going to bring you an EDTA blood sample, and I want you to tell me whether there's Bartonella in it, and I want you to be right 98% of the time. We started on that 20 years ago, and we could do it better than anybody in the world, I believe, and we still can't get 98% of the time. At my best guess, we're probably hitting 80% of the time, 70% of the time, but you never know how many you're missing really. And so in regard to trying to do that over the years, working with Ricardo, the first thing we worked on was a liquid culture media, Bartonella alpha proteobacteria growth media. And so for blood samples, we actually put them in a growth media. We'll PCR from the blood, which is almost invariably negative, and then we'll PCR from the growth media at 7, 14, and 21 days. And we also published another study in the Journal of Clinical Microbiology saying if you test 3 samples from a patient collected within a 7-day period, statistically, you're more likely to detect Bartonella than if you only collect 1 sample. That's because the bacteria is in and out of the blood. And but if you look at that, that's a research platform where we essentially sample that patient because we PCR from blood, we PCR from serum, we get 3 different samples. So you add all those up, that's 18 PCRs done over a 21-day period to be able to say whether somebody's infected with Bartonella or not.
So like the second approach, which is sampling multiple times in a week, makes complete sense to me because it's kind of when's it shedding, when's it transiently in the blood. What's the gig like? If I send you, because the scientist in the back of my head goes, hey, if I send you a sample and you have all of it, why can't you amplify the DNA the first time enough to see it? What's so special about putting in that culture medium, that growth medium, that allows you to get a more accurate result?
It's a numbers game. And, you know, what PCR, polymerase chain reaction, has allowed us to do in regard to detecting DNA is it's allowed us to find a needle in a haystack. And an example I use when I lecture to students or veterinarians or whoever is I'll ask them, do you believe, and you can be my student, Tom, do you believe there's starfish in the Atlantic Ocean?
I do.
Good. I have identified a starfish gene that is very specific, only in starfish. And I've developed a PCR assay that allows these primers to set down on that gene. And I'm going to ask you to go to the Atlantic Ocean with a 5-gallon bucket, dump it in the ocean, and bring it back to my lab. Okay? Right. So you know how many starfish are in the Atlantic Ocean. So question number 1 is, were you lucky enough when you dumped the 5-gallon bucket into the Atlantic Ocean to get 1 or 2 or 5? And then you bring it back to the lab. I can't process 5 gallons. I really appreciate you got all that water, Tom, but I can only process about a half a pint of that, which is what we can then extract. So and then once I've extracted the DNA from that, I can't put all that DNA through the thermocycler because it would start smoking. It's an exaggeration, but it wouldn't work.
Right.
And so each step in that molecular diagnostic process goes from the Atlantic Ocean to a very, very small quantity of DNA that is mostly host DNA, right? It's mostly host DNA. So if I'm testing you, it's mostly your DNA, it's mostly the dog's DNA, and I'm looking for that needle in a haystack. Now, what's changed, and it's changed literally in about the last 5 years, and we're among the first labs in the world to apply it until COVID came along, and then everybody applied it to COVID pretty rapidly. And that's what's called digital PCR. And digital PCR is more sensitive than what historically was called conventional PCR and then quantitative PCR. And the reason it's more sensitive is with those other 2 testing modalities, you're starting with a single strand of DNA, and you just keep making more and more and more of it until you can, in the laboratory, identify it and say what it is, which we do by DNA sequencing on a diagnostic basis and a research basis. So digital PCR, and I know this is all a little confusing for the average listener, but it's important, is literally doing somewhere, depending on the equipment, the manufacturer, and how it's designed to be used, 18,000 to 22,000 individual PCR reactions. So again, thanks to the Cohen Foundation in New York, we were able to buy a droplet digital PCR machine, which is about $250,000 investment for research purposes here at NC State, just before the pandemic. And I say just before the pandemic because if we'd have waited about 2 months longer to put in our purchase order, they'd all been sold. So the timing was important there. And honestly, it is changing our understanding of Babesia tremendously. And we've focused on Bartonella first, Babesia second, and we're leaving Borrelia for last because mostly it's the most controversial. And it's also the one that we're finding the least evidence from digital PCR that we can have DNA of that genus in the blood.
Well, that's kind of that'll be interesting to see as more of this research comes out, because I know you guys are doing this all the time, because that is one of the things, like the Holy Grail, I think, is like the accurate diagnosis and really finding out what's going on. So you really highlighted like some of the challenges, like, and you were able to answer one of my other questions, which is like, if I look at a DNA PCR test from one lab versus another, why might I get a different answer? I think that's pretty clear from what you just said. When we're looking at serology, I think this is one of the challenges that both clinicians and patients run into is, why are we getting different results, right? You know, it's just like if I check at Galaxy versus another lab, I might get 3 different results. Like one might be floridly positive, one might be equivocal, and one might be completely negative. Yet I drew the sample on the same person on the same day, and I did 3 tubes of blood in a row, and I just sent them off. I mean, what's going on there?
So there's a number of factors that could be involved in why you would get different results from different laboratories. But I think the most important factor is that different laboratories are using different isolates of the organism generally to determine whether the patient has made antibodies. And for instance, many of the large commercial labs use Bartonella Henselae Houston 1. Houston 1 is the type strain. It was the first isolate made from an AIDS patient, obviously in Houston, Texas, and was deposited in the ATCC. Houston 1 is not the most frequent Bartonella Henselae strains that we get out of dogs, cats, or humans that are sick. And that's Bartonella Henselae SA2. So at Galaxy uses an SA2 strain rather than a Houston 1 strain or a couple of the other strains that are less frequent. And I think there was a study done 20 years ago where they looked at people in Sweden that got bit by a cat. And they had serum from all these people, so well-documented cat scratch disease patients. They tested them against isolates from a cat in Sweden, isolates, Bartonella Henselae isolates from a cat in Sweden, from German isolates, French isolate, and the US Houston 1. And what was fascinating is that the highest prevalence that they got, the highest evidence serologically that those patients had actually been infected with Bartonella Henselae, was used in Swedish cat isolate. The next highest was Germany. The further you got away from that site, the lower the antibody prevalence went, with the lowest essentially being, which pretty much matched with the French isolate, Bartonella Henselae Houston 1 in the United States. So, you know, there's plenty of studies out there. The other problem that's not a laboratory problem, and this is particularly important with Bartonella and likely Babesia, is patients ultimately stop making antibodies to these organisms, as well as I can tell. They become the immunologic term essentially anergic. The immune system decides to stop making antibodies. So, you know, we did a study in dogs where the dog had cancer and hemangiosarcoma, which is the 3rd most common cancer that as veterinarians we see. And in 75% of those dogs, we could document infection by PCR from blood, serum, tissues, multiple tissues. So, and a lot of testing was done to get up to that 75%. Only 6% of them had antibodies to the Bartonella that they were infected with. So we believe that that infection that may have contributed to the development of that cancer, and that's clearly not proven at this point in time. It could be that the cancer suppressed the immune system, the infection was opportunistic, or it could be like papillomavirus, that this chronic infection induced a cancer. So that's probably one of the biggest problems.
Yeah. One of the other things, it's so interesting to me, the interplay between these infections acutely versus chronically in the immune system. And I think that that's one of the long-term challenges. And then, so many things, in terms of how they drive inflammation, even in that chronic state. One of the things that I often get asked, and I'm always curious to hear what someone who's in the trenches, so to speak, which I think is probably a poor choice of words when talking about Bartonella quintana and stuff. But anyway, it's like, do you see a serofast state? I mean, like in Bartonella, Henselae at least, we're looking at IgGs as sort of analogous to IgM for many, many other infections, kind of saying it's recent or an acute infection. But have you seen either animals or, well, I mean, humans are animals, but, not any sort of your patients, if you will, that end up with like a positive Bartonella Henselae, say IgG from, that just stays there, and it's like 1 to 256. It never really seems to go down, yet clinically they're great. And you've maybe checked for direct evidence through PCR and culture. Like, is that something a phenomena you're seeing, or is that sort of, if they are making antibody in your research, have you seen that really probably is more truly like ongoing infection?
So that's a good question. And I'm trying to think about how to best approach it. One, we essentially in our research, or in my lab, we thought that you had to be a veterinary worker, a farmer, someone that had a lot of exposure to arthropods or animals to become infected with Bartonella. And we now suspect that it's pretty hard to get through life without being exposed to a Bartonella species. Again, emphasizing the fact that most people probably, once they're infected, immunologically, they eliminate the organism, and it's a done deal. But the studies we've done with veterinarians, if we go to a national meeting of veterinarians and we indicate we're doing a study and we're willing to test them for Bartonella, we can document almost a third of them having Bartonella in their blood. We then did a study with Brazilian physicians where, using the same techniques that we developed, this enrichment blood culture followed by PCR in my laboratory, and they were able to document infection in the blood of 3% of Brazilian blood donors with the techniques they were using 10 or 12 years ago. They just went back and revisited that, which gets to your question on differences in different labs. So then, instead of using a single PCR target of Bartonella, so instead of going after one little gene in the bacteria, they went after multiple genes, and they almost increased their prevalence to 20% in Brazilian blood donors. So these are healthy people. So I think the reason a lot of people have antibodies is a lot of people can be infected with Bartonella and can be totally asymptomatic, which is going to further confuse all of us in regard to trying to understand the exact role of this genus of bacteria in chronic illness over time, because it's going to take a lot of money, large studies funded by NIH, and looking at samples sequentially over time, perhaps in a high-risk population like veterinary workers, where there's never been a national veterinary worker lifetime study.
Yeah. Wow. I mean, it is so interesting, because then I'm like, well, can we use that blood? Can we do, is that viable? I mean, now, because I mean, it's, is it, there's a lot of questions that statement raises.
I think, again, Galaxy actually tried to get a study with the American Red Cross to screen blood donors in the United States, and it never went anywhere. And I think one of the reasons is the implications are substantial, and sometimes it's better not to know. If you ask me, would I rather have a blood donation of Bartonella containing blood or no blood donation if I'm dying, I'll take that blood that's got some Bartonella in it.
That's right. Yeah. And then just put one of our business cards on the bag of blood for later. So, I mean, what a tour de force of kind of like talking about the science behind it. Because I think that the diagnosis of this is like so critical. And part of it is this lab testing and understand why there are differences in different labs, why we might like ask our patients to go to an out of network or, a fee for service lab because we need to get the right answer to help them get better. Going back to, I want to know what the question is. The question is, do you actually have
Right.
it? Like, because a lot of times I think we start treating things as if we have it just because somebody decided they had that. And I mean, I've had cases of people who were told they had babesia because they had shortness of breath going up the stairs. And I'm like, that's not necessarily air hunger, like people saying babesia. It turned out that it was metastatic cancer, and they lived for another 6 months, which was a shame in my mind because we just said it kind of looks like this, so it must be this. And we do a lot, I think, as a general community in the Lyme community or the chronic infection community, people decide what they have, and then they just go try to tell their doctor, or their doctor decides everybody has this. So I think it's really important to have this conversation, and I appreciate it so much about the lab diagnostic approach. But the other avenue of diagnosis, I think that's really so important, is not to forget that as clinicians, we actually have patients.
Right.
Then we're not just looking at their blood, but we're actually looking at talking to them, figuring out their history, and figure out their symptomatology, and does it match with what our blood tests are showing us. So I know that you've published great papers with, Alan Lewis, who trained in my office a long, long time ago, with my good friend Amy Offit and others. And and you and I have even in the past talked about things, but then that pandemic thing happened. So we didn't get that one off the ground. But what are you seeing as kind of like the symptoms that people should be looking out for from your perspective?
One thing I should say, that with the advent of droplet digital PCR in our laboratory, what Lyme literate physicians have been saying for a long time is true. And I'm saying true on a DNA basis, that some patients are only infected with Borrelia based on digital PCR. Some are only infected with Bartonella. Some are only infected with Babesia. But some patients that we have tested in the last year and a half since we've used this modality are infected with any combination of those three. So that further complicates trying to use symptomatology exactly in an individual patient, because I'm a practicing internist as well. And when I'm across the street in the clinic with my residents, I'm trying to figure out what's going on in that cat or that dog. And, and I know the kindest form of therapy is an accurate diagnosis. And it is the reason that in our research, we try so critically to put a DNA fingerprint or an antigen or something on it, so that we really know, should we be treating with a drug that'll kill Bartonella or Borrelia or Babesia, because really there's different drugs for those different organisms that have, different efficacies. In regard to symptoms, it's pretty clear that as we look at neurological symptoms, and one of the major focuses of one of the PhD students in the laboratory right now is cell culture work related to neurons and microglial cells, so that we can better understand exactly what's going on a cellular basis within the brain of patients infected with Bartonella. And it's probably the scariest area in one respect, and the most important and promising area in another respect relative to neuropsychiatric illnesses, because you mentioned Dr. Lewis, and Dr. Lewis and that team of physicians were able to take a boy that had essentially been managed for almost 2 years with up to 11 neuropsychiatric medications, was homicidal, suicidal, and because he developed these tract-like lesions that a subset, very small subset, I think, of Bartonella patients develop, a nurse in Dr. Lewis's practice actually suggested he be tested for Bartonella, which he was in my research lab, and was infected on a DNA basis. And after treatment, he had total resolution of his symptoms, his illness. He went off all his neuropsychiatric drugs, And that's the promising part. If we're right, and if Bartonella was the sole cause of what was going on in that young man,
Yeah.
and if he had failed 2 years and $500,000 worth of medical interventions, and actually a single bacteria, which again, I'm emphasizing it's possible, but we don't know that, was able to reverse that course, that is very, very important. And as you know, we did a pilot study. We did a study with UNC that wasn't supposed to be a pilot study, with Dr. Flavio Froelich there, who's a neurobiologist and physicians at UNC. And statistically, if a patient was going to UNC and we tested their blood by digital PCR, they had Bartonella DNA in their blood, compared to controls that were tested at the same time that did not have Bartonella DNA in their blood. Mm. So we've actually now done another study with Columbia University that is currently under review, and we essentially found similar findings. So I think there's more evidence, as far as I'm concerned, that being chronically infected with Bartonella, either in your blood, your endothelium, or potentially within your central nervous system, could contribute to a spectrum of neurologic disease. And so that's why one of the major focuses for us in the laboratory right now is try to understand this bacteria better on a cellular basis and what it's doing in turning things on and off in cells.
Yeah, it's so interesting because back in the day, I was so fortunate to train with Charles Ray Jones for many, many years. We happened to live right down the road from each other, so I shared lots of sushi, and I learned about Korean bibimbap from him, and which are the things you remember. But these were I could go down and spend a lot of time, and I heard about this thing, PANS PANDAS, right? The pediatric
Absolutely.
acute onset neuropsychiatric syndrome, which is what you're referring to this patient having. And he always broke it out, and he called it like infection-induced autoimmune encephalitis. And then I kind of step back and I look at it as any kind of toxin that is known to trigger it can lump in there, because there's some other things besides
Absolutely.
infections. But we trigger autoimmunity and we trigger inflammation, whether it's in the brain or in sort of more in the joints and such, where we might trigger rheumatoid or lupus or something like that. But it's interesting to me to think about that, because in the case that we've been chatting about in Dr. Lewis's clinic, they treated him like for autoimmune encephalitis, but it didn't work. And then a lot of my patients, I kind of go, okay, that's an extreme case. Although in what I do, it's not that extreme because I have a selection bias. People come to me because they know I treat that. So like if I'm an HIV doctor, I may have a lot of HIV patients because that's my specialty, but that doesn't mean everybody has HIV. But what I think about is like so many of these people who are on SSRIs or SNRIs, these antidepressants and these anti-anxiety medicines, but they're not working normally. Like I know I was trained like, hey, maybe you might have to go through a couple or combine some. But when people don't react normally, I step back and I go, what might I have missed? And in this case, it really refreshed me, because I have always said if there's a single genus of bacteria out there that could cause things that look like autoimmune encephalitis triggered by an infection, but not be, it's the Bartonella genus. And I always say, and I don't know if you've seen this, but I always say, hey, if you think your kid all of a sudden needs an exorcism out of the blue, you might want to think about Bartonella. Not saying throw anything else off the table, but think about it. So I'm always looking like on all three of those categories, the infections, the autoimmunity, and the inflammation, because they addressed in that particular child two of those things, but they missed the infection part, right, until Alan and I think Bob Mosiani was in on that too, yep, and you. And so great team approach. And I guess it just reminds me that Bartonella can trigger infection-induced autoimmune encephalitis or PANS, but it also can look like it and not be it. And to me, if you treat the infection, it all goes away. But I mean, that kid resolved so quickly once he got the right diagnosis. And if I remember correctly, and please correct me if I'm wrong, because you probably know the case better than I do, but he was serologically negative.
Yes.
And it was this advanced PCR approach that really was the key.
Yeah. It was enrichment culture followed. At that point, we didn't have digital PCR, but by quantitative PCR, we were able to amplify enough of the DNA of the bacteria, like that needle in the haystack thing, and we were able to send it to a commercial laboratory, and they sent a sequence to us, and that sequence was Bartonella Henselae. So we were able to put a fingerprint, DNA fingerprint, on what was in his blood at the point that we got to sample.
So is that, again, I mean, not to beat the horse to death, but the accurate diagnosis is so critical.
Yeah,
because ultimately,
well, it's just the reason that as you've introduced so many times, trying to understand chronic illness is very difficult. Many of the testing modalities we have are not adequate at this point in time, but to get to a point where we can all agree that we need further development, further work, further funding, we need that direct evidence. Indirect evidence, many physicians are never going to accept. One of the big movements is to use artificial intelligence and to look at various cytokine profiles over time. And that may help, but my problem with that is it's going to take a tremendous amount of data to actually develop those algorithms. And it's going to be so patient variable because, if you get a bee sting and I get a bee sting, you may develop anaphylaxis and I may rub a little something on it, and that's the end of the story. So,
Right.
we really need better direct detection. And that's what we've continued to work towards. I think that is now what the National Institute of Health has said in regard to the NIH Cohen Foundation initiative. And hopefully they're going to put their money where their mouth is.
Yeah, in the back of my head, I go, the direct detection, I mean, it's gotten so much better, but I, as a clinician, still feel like the results are miserable in chronic infection.
Absolutely.
And right. And so that's the challenge, because I'm like getting all excited when you're saying that. I'm like, oh my God, this is great. This is what we really need. I'm sick and tired of going, hey, Lyme's a clinical diagnosis supported by lab data. I've got history of infection that was kind of maybe treated or not treated or partially treated. I've got symptoms that developed over time that are slam dunk Lyme or Bartonella symptoms. I've got a patient with antibodies, and everybody, oh, that's not what they have. Oh, well, it turns out they had their tooth thing done at the dentist, and they got amoxicillin or they got doxy, and they felt better for a week or two. Oh, that's just, that's not it. But like, I'm just thinking, like, the case that you presented with or the case report that you and Dr. Offit authored, where we have someone with autism spectrum disorder, which, a lot of us say, hey, PANS and PANDAS or infection-induced autoimmune encephalitis kind of overlaps a little with autism, but it's kind of different. But here's a kid with learning disabilities who you found polymicrobial infection, and appropriate treatment led to dramatic improvement in someone who otherwise would be considered by the medical establishment as untreatable.
Yeah, that obviously was an extremely complicated case because that particular patient, as a child when he was born, had some very well documented neurologic abnormalities, and everything, I think, then was complicated because it was how much was related to a congenital abnormal formation of the cerebellum and part of the brain. But as time went on, and the mother of that particular child probably deserves as much credit as Amy and I in making observations that made her believe, as you alluded to, that there might be an infectious etiology to it, not giving up and continuing to pursue. And Amy and I tried to document through the medical records every different laboratory and every different test that was done. And we did that to make the playing field as accurate and fair to everyone. And to make people, if they actually critically read that, realize that there was a lot of testing done, and the vast majority of it was negative, and different labs didn't agree at different points in time. But there was enough evidence of infection with more than one organism to support its presence. And I think, again, as you alluded to, the proof in the pudding is that child finally graduated from high school and got admitted to college, which was predicted to never have been possible. And Yeah. I mean,
Right?
you know,
Wow.
I've recently said we're kind of learning about the genus Bartonella one patient at a time. And I think that's true. And we obviously need to do a better job with large studies, very structured studies. It's the reason we try to publish as many individual case reports that we think are important as possible, because if at least the science is good, it can be used as a basis to build upon to do larger studies by other institutions.
Yeah, and Ed, I mean, I love having the opportunity to chat with people who have made a difference in my patients' lives or even in my family. I mean, I'm somebody who had Lyme and Babesia. That's kind of how I sort of got into this whole thing. Although I got better, and then I was trying to run away from it and just get paid to meditate doing osteopathic cranial work in my office. And then I felt somebody had an infection, and you get out there and do it. But, my daughter got Bartonella when she's like 3.5. It is presumably from the cat, because we had cats before I had any clue about any of this, but they were indoor, outdoor cats, like you said. So the accessibility of accurate testing and open-minded researchers and clinicians makes all the difference in the world. And the thing I love about your approach is like, it's not just like, hey, just everybody's got Bartonella. It's like, no, let's find out who has Bartonella. And more importantly, not who's just been exposed at some point and cleared it, but who currently has it. Because that's kind of, for me, the holy grail. It's not like a friend of mine in Connecticut was like, hey, I know you specialize in Lyme and everything, but like pretty much everybody in Connecticut's been exposed to Lyme. So how do you determine who's been exposed versus who's actively infected? And I was like, that's a great question.
Well, and Tom, you know it and I know it, that Lyme disease is the most controversial infectious disease in the United States of America. And it's because the only test we had was serology. So the amount of debate and argument and misidentification and misunderstanding that has evolved around Lyme disease can be essentially based on a two-tier test, where we use an ELISA test and we follow up with a Western blot. So, I don't think you can have a better example of that, where serology, and it's exactly what, that person said to you, we're in an area that's highly endemic for Lyme disease. A lot of people are being exposed. What's going on with those people that actually get sick? And, some of them, I think, get sick because they're co-infected.
I agree. And it's actually interesting, as you were saying that, I'm even thinking a lot of the cytokine and inflammatory marker research that's come out through our understanding of COVID and the AI learning they're doing. They're finding sort of like some patterns that may be more likely to be Lyme-induced rather than post-long COVID-induced. But again, it's like, I think a lot of us who focus on the immune reaction to these infections, it makes a huge difference, right? And it's like, what is the ecosystem of the human being, and how is that ecosystem being impacted by the members of its community, including these at times polymicrobial infections? So, yeah, and I mean, I guess before I forget, a minute ago, what I was alluding to, I wanted to say thank you for the work you're doing, because just like the 2 case reports we've talked about, I've had kids with acute onset of food restriction, which is one of the classic PANS presentations. We had some stuff through Quest, local lab, whatever, using one of those basic the Houston 1 type of things. And I had to treat them clinically. And I was like sweating bullets because I couldn't get the right test, and they couldn't afford to get this additional testing. Thankfully, there are people out there that they could apply for support. They got support, and they were able to get accurate testing through Galaxy, confirmed my clinical suspicion of Bartonella. But it took me 10 months of treating him to get him to start eating regularly, and started to gain weight. Neuropsychiatric symptoms started to kind of calm down, and ultimately kind of return to their baseline, their pre sort of infection baseline. But I was getting a little bit lucky, but I didn't know what I was really treating. I was hunching. And so to have people out there like yourself who just will not stop until we get like the actual scientific answer and continue to push the field forward. I've seen it in my personal life and my professional life. And I think that one of the things people in our field don't get enough of is thank you. So I wanted to just say thank you. And then, kind of as we kind of start to wrap things up and things, like what what would you like to see next? And like, where are you going? Like, if you could come up with, you had as much money as you needed, everybody would give you all the equipment, there were no back orders. Like, what is the thing that you really see as like the next thing that Dr. Breitschwerdt really wants to bring out into the world?
Well, I appreciate that question, and I've already asked it of myself a number of times. And fortunately, one of my PhD students that finished 3 years ago went to the University of North Carolina Medical School and did a postdoc in a very good lab working on Mycobacterium tuberculosis, which, despite the fact TB's been around a long time, we still have some problems with tuberculosis worldwide. And Pradeep is back with us now. And what I would really like my lab to produce is an excellent diagnostic test that is serologic and specific, and will differentiate a recent exposure from an active exposure if that's possible. But the thing that I would rather see us be successful with, if we're not successful with that, is to identify an antigen that we can protect cats and dogs so that people can sleep with them and not worry about getting Bartonella. So if we can keep the animals from becoming infected, we can interrupt, just like rabies. If your dog's vaccinated for rabies, the chances, even if it's bitten by a rabid raccoon, of that raccoon infecting the dog and the dog ultimately infecting you is almost none. So, awesome. Yeah, our goal right now is to try to see if we can come up with a vaccine target, which I think is really critical for this genus of bacteria. Ideally, we'd like a target that would go across all these Bartonella species, so you don't have to worry about whether it's coming out of a rat or it's coming out of a cow or it's coming out of something else. But at this point, we really want one that's going to take care of any Bartonella that might infect a cat or infect a dog and serve as a source of infection for family members.
That'd be phenomenal. I always love it because it's like, I think as a clinician, I actually expected a pretty different answer. The first part of your answer, I was like, I kind of saw that coming. We obviously want better testing, but that's what I love to hear. And that's why I love this conversation, because we can cut through some of the myths about the presentation as well as the science, as the diagnosis and the testing, but then to see where great minds like yours are going to kind of like, it's not just like, treat the cat. It's prevent the infection and minimize the spread across the board. And then, in this case, I was talking about treating an individual cat because of where we went in the beginning, but really looking at how do we just stop the transmission or dramatically decrease. And I think that that's a really interesting approach to take, and refreshing to hear, because we can't like vaccinate everybody for like every person for Bartonella, and we can't, it's just like, I'm assuming that's like way off, but it's I think that that's a really brilliant approach to take.
Well, I think for us that's a major goal. Probably understanding the role of Bartonella in neurologic diseases and neuropsychiatric disease, and trying to protect that human-animal bond, because, when I get home in the evening, my German short-haired pointer just goes absolutely crazy in running around, and he makes my day. And I took an oath as a veterinarian to protect animal and human health, and I think one way to do that is to develop this vaccine.
That's incredible, Dr. Ed Breitschwerdt. I think that's a great place to close, because that's really, I think it's all about that human bond. And for me, the animals in my life have always been there. And even if we don't have animals in our lives, we're out in the environment where we're exposed to some of these other things. And so much of it is, for me, about community and coming together. And that's what I love about the people that I get to work with in this profession. Is it is a very controversial field, mostly because we don't know. We don't have the science to do it. It's not like this doctor is an a-hole and that doctor is right, and we're really on teams. I think we're on the team of, and sometimes some of the clinicians forget this, I think, but, and researchers for that matter, because it's like we have our tenure and our little tie that's a little too tight. But really, it's like, it's about the community. And if we're a physician, whether it's a veterinary physician or a human physician, we've taken an oath to protect the sanctity of the human, being or the animal being. And I really like how you said the community, the bringing together that bond, because what we saw with COVID and what we see kind of in this chronic illness world is there's this spike that gets driven between, and sometimes even in families, it's like, oh no, you don't have it because the test was negative and it's like, no, like these people are really suffering. I don't care what they have. Let's find out what they have so we can get them better and we can mend those bonds. And the work you're doing is really enabling us, because these children we were talking about, their lives were going, I mean, they're wonderful where they were, but man, I'm sure like if you're not even going to be able to go through high school and now you graduated college, that's a pretty different quality of life and contribution to society. Imagine what that family feels like. So I just, again, like want to say thank you so much for the work you're doing and bringing our community together, and like the whole human animal community, not just the Lyme community, because we all kind of try to stick together, but it's like everybody needs to come together to solve this. And I think you're on the cutting edge of doing that. So I want to say thank you so much for doing that and for being here today.
Thanks, Tom. As I said at the beginning, I really appreciate the opportunity to share. I will clearly share your thanks and the thanks of others, which I do routinely with the people in the lab. Fortunately, right now, I've got the best team we've ever had on a research basis, and that's not due to the NIH or CDC that's not funding any work here in my lab, but due to foundations and donors that actually contribute to the Bartonella Research Fund that we have here at NC State. So if it weren't for the people out there that really believe in what we're doing and care about what we're doing, we wouldn't be doing this. So
yeah, well, and one of the things, I'll make sure in the show notes that we get all the kind of the links to where people can find out about the research you're publishing, Galaxy Diagnostics, and the foundation too, because if there's someone out there who is interested in helping to support this, if you happen to be at a place where you can, every few bucks count.
No, absolutely. Absolutely. Yeah. I appreciate that. And honestly, it's I'm the guy that has to worry about everybody's salaries at the end of the year or the beginning of the year. And, I wouldn't want to lose anybody that I've got in this lab right now because we ran out of funding.
Well, I'll tell you, getting a good team together can be so challenging. And like you said, somebody went away, but they're like, oh, I want to come back because I believe in the mission. That says so much to me as an employer.
Yeah.
Just leave the doctor part alone. Everybody wants to work with you because of your mission. And so anything we can do to help, we definitely are getting this out on all the social media channels, sharing with our email list, which is substantial. And one of the things I'll say about my community, and I want to say thank you to everyone for joining us today, like and subscribe to the podcast and share this with your friends, because knowledge is power. I mean, I've been putting stuff out that like people are even saying, hey, I never saw that classic symptom, and the reason we talk about the classic symptoms is so that people don't miss that. But then really what we dive into on the podcast and the Lyme Insider is to really talk about the complexity and what we're seeing sort of when you're not the classic presentation. And we need more research to really, like we've talked about in this whole episode, to really nail down that diagnosis. And so if we can support the work of Dr. Breitschwerdt and others like him, who, when the government's not doing it, that's how we take control back, right? And I mean, I know I even have children who donate. They got some funding for their diagnosis and treatment of tick-borne illness from an organization like Limelight Foundation, and they get better. And they're like, "Hey, I'm going to send $10. That's all I got. I'm 9 years old, but they donate $10. So $10 to a 9-year-old is a ton of cash. And I'm not, hey, if you have the opportunity to do this, or someone who can donate, do that. But at the very least, support the work that Dr. Breitschwerdt's doing. Support our podcast so that we can continue to provide this free information. And we can also support people like Dr. Breitschwerdt, because if we don't, we're not going to get the right diagnosis, which means people are going to suffer a lot longer than they need to. So, Ed, I mean, my gosh, thank you so very much for being here. Any last words you'd like to say before we close out here?
No, Tom, I again would just emphasize what you said, is that we're all in this together, and we need to think about the community and the planet that we live on. And we need to take good care of the animals, the humans, and the planet.
Well said. Thanks so very much. And everyone, thanks for joining us today.
Thank you, Tom. Take care.
Well, everyone, thank you so much for joining us for this episode of the Lyme Insider. I mean, I was just blown away by all the amazing information that Dr. Ed Breitschwerdt was sharing. And one thing that really gets me, Ed, is that the whole conversation is about science. It's like we're seeing things clinically, we're having experiences, we're having emotional reactions to them, but he's diving deeper into the science. One of the things that came up right after we turned off the camera that I wanted to share with you is that Ed was talking about, and I'm paraphrasing a little bit here because I'm adding the silver lining part, but kind of the silver lining of the pandemic is that it dramatically fast forwarded the developments in new diagnostic testing, especially like the digital droplet PCR and other things like that. And so that to me is really important that that's coming out here. And Ed was saying, it was kind of like the space race to new techniques, right? So a lot of the new techniques that are coming out of the pandemic are really going to revolutionize the way we look at or able to diagnose more through direct methods, which has always been such a challenge, so many of these infections. And the other thing that I say as a practicing clinician is that clinically, many of us who are treating sort of long Lyme and long Bartonella, if you will, really knew how to minimize the impact of long COVID. So it's not that anybody wanted the pandemic. It's not that anybody wants Bartonella, but we have amazing researchers who are really fast forwarding this. And we've seen so many changes in the last 5 or 6 years that have really pushed forward. And that's what the Lyme Insider is about. We're going to get the researchers. We're going to talk about what the science really means and where the gaps are so that you know what's the truth today, because that may change in a week or in a couple of years. But then also, like, where are we going and where can you support, your family, your friends in regaining their health? And also, if you happen to have the ability to help some of these foundations, because one of the other things is, Ed and I were just talking, and it's CDC published a thing called the National Public Health Strategy to Prevent and Control Vector-Borne Diseases in People. I did a search. They had 3 mentions of Bartonella. 2 were in the references on the same line, so it was just a web URL. And that was the reference for Bartonella quintana could cause a problem from body lice, and that's all they said. There is no mention in that report from, I believe it's 2023, there's no mention of that they're going to support or fund any Bartonella research. So this is where it's so important to understand that these private foundations like the Cohen Foundation, things like Global Lyme Alliance, are funding research that the government refuses to fund. So within the last 2 months from the time we're recording this, the CDC has taken a stand that Bartonella is not important, right? They barely mention it. They don't mention cat scratch disease. They don't mention Vinsoni burkhoffii. So just know that people like Dr. Breitschwerdt, labs like Galaxy Diagnostics and others, foundations like the Cohen Foundation, foundations like Global Lyme Alliance are funding the research that is so desperately needed. So I just wanted to say thank you so much for joining. Please subscribe through whatever your favorite podcast channel is, whether it's audio or video. Really support the Lyme Insider. Share this with your friends. It costs you nothing. It helps our podcast so much to get this critical information out to the people who need it the most. And together, our community, we can come together and really make a big change. Because the last thing that Ed was sharing with me before we kind of popped off after I hit stop on the recording was paradigm shifts are difficult. It doesn't really happen quickly. But the way we shift this paradigm is we do it together. That's what the Lyme Insider is all about. That's what the work Dr. Breitschwerdt is doing. And I want to say thank you, because without your support, none of this would be possible. Have an amazing day. Have an amazing life. And we'll see you in our next episode.